So don't forget about the adrenals. If your patient comes to you and they're tired, you've got to be thinking a few things. You're thinking methylation, you're thinking mitochondria, and you're thinking adrenals. So, and probably thyroid. Some of my favorite things, so I like for testing, I do like saliva testing and adrenal stress index. I typically use one from diagnostics. I found it to be quite accurate. Eleutherococcus is an herb, can be quite stimulating, really supportive with some of these herbal protocols. You want to take it earlier in the day though, because it is a bit like a stimulant. Also a great one if you're trying to get someone off of coffee, that just load them up with eleutherococcus. Ashwagandha and rhodiola are nice because they're adaptogens. And the word adaptogen means, you're bringing down cortisol when it's too high or you're giving it a boost when it's too low. So these are nice ones that you can give kind of steady throughout the day. One I'd like to highlight is phosphatidylserine. So for any of you doing adrenal tests, you probably find that with your patients, they are tired during the day and they're not sleeping at all at night. What you'll see on an adrenal stress index is like there's almost no cortisol output early in the day and whoops, it spikes at bedtime. So they have that cortisol reversal. Phosphatidylserine is one of the only things that can bring down that high cortisol. So it can be a really great thing to give at bedtime to help bring that into a normal range so they can sleep again. Or if you do testing on someone and their overall cortisol pool is high, they're always in a high cortisol state, they're probably always in a high pain state as well, you may want to give this throughout the day and just kind of watch for fatigue, and if you're getting some fatigue, back that off. But it can reduce that cortisol, can reduce that intensity. So this is probably your anxious, tense sort of patient. It's going to bring that down. DHEA can be helpful. I would only do that in adults, and I find the doses, I like to do sublinguals in doses much lower than they're classically doing. So probably in 5 to 10 milligrams is the most that I would go unless I'm really trying to boost testosterone in a man. Pregnenolone. Really great both for men and women. Pregnenolone is a precursor to progesterone, but also supports that adrenal pathway, and it's one that your body can regulate really well. And I've got to say, especially with my chronic fatigue, my Lyme females, I'm seeing progesterone get sacrificed like immediately. Our adrenals get tanked, progesterone comes next. I'm seeing women having horrible menstrual cycles or like very erratic menstrual cycles, absolutely no libido at all, and often going into menopause in their 40s, which is just crazy. Doing some pregnenolone can be a nice way to start with that, so could chaste tree. But the pregnenolone has been fantastic. And then I also am a huge fan, so B vitamins, of course, but of adrenal cortex extracts. So the glandulars are food for the adrenals. So it's not the same as giving hydrocortisone. It's actually giving food for the adrenals, so they actually have some energy to draw on to make cortisol at a rate that they can control. So I'm finding with some of our patients, if they've been sick for 20 years, you probably need to give some food for those adrenals so they can function. So I often will do 2 in the morning, 2 a couple hours later, and possibly 2 at bedtime, because especially if they're not sleeping, it may be because cortisol is trying to spike in the middle of the night, and if you give that food at bedtime, they might be able to sleep through the night. Okay, toxin elimination and nutrient support. Here we go. So mitochondria. There's going to be a lecture after me, so I'll skip over this. Mitochondria make ATP. It's the gas that runs the car. If your patient is depleted, they can't exercise, they can't walk to the mailbox and back, or they can't go shopping without being wiped out for a couple days, their mitochondria are tanked. This is not true mitochondrial disease, this is mitochondrial dysfunction, and I'm seeing it in 2- and 3-year-olds. So do not think that this can't happen in a child. These are people, they've lost muscle mass, they just can't do anything. This is your patient that when you try and do methylation support, you give them a B vitamin shot and they get tired. You're like, what's going on? It's because it forced that cycle, and that was all the energy that they had, is to feed that cycle. So you really have to think of this as a foundational sort of piece. So clinical signs, I've talked about that. What system does it affect? Everything. So some lab indicators, you can refer back to this. But there are some nice lab indicators without doing a muscle biopsy or anything like that you can just look at on a basic test that's covered by insurance. So maybe they have that low RBC folate, that really low BUN to creatinine ratio, maybe low cysteine levels, elevated AST or ALT, low glucose. I'd love to do an organic acid test, which is a urine test. It'll definitely show you some good markers for that. And a plasma amino acid test is probably going to show you the most. You're going to have a high alanine to lysine ratio. Let me give you I'm going to jump to this. So there is a really nice article that Dan Rosignol and Richard Fry put out in 2011 that goes through a whole algorithm of how you can take like a plasma amino acid and a chemistry panel and decipher if there's indicators of mitochondrial dysfunction. Really a nice way to look at that. I've tried to highlight some of the other pieces, and I'm happy to like send any of you handouts and things that I've used in the office, because I am super type A, so whenever I read something, I always put it into like, how can I look at this with my patient? So what's my little cheat sheet? So I'm happy to send any of you my cheat sheets. There'll be a lecture on this afterwards, so I won't talk about it too much, but some of my favorites for treating mitochondria: big monster doses of CoQ10, acetyl L-carnitine, or possibly even prescription Carnitor. I guess maybe the thing I'd like to highlight with mitochondria is I thought the whole mitochondrial thing was BS when I first started it, because I was all excited about this probably 12 years ago, started treating patients with it, and people weren't getting better. I'm like, what's going on? I was completely underdosing. So the whole thought is you have to do a loading dose, because mitochondria are within every cell of our body. But the cells that are affecting our energy and our symptoms are more in the nervous system and our adrenals. When you're taking something orally, it's first supporting the first cells that it encounters, everything outside of the gut, and going from there. So you have to do these loading doses to actually get the mitochondrial support to the cells that we need it to. So usually you're looking at a good 2 months of a high dose, and sometimes that's 10, 15, even 20 pills a day. That's where sometimes the prescriptions come in handy at the beginning, but I usually make a deal with my patients that if we're going to start this, we're all in. This isn't something that you do a little bit of and everything else. Otherwise, you're wasting your money. If we're going to do this, let's really commit to 2 months of doing this, and then let's assess if you're feeling better, and then at that point, you drop back to maintenance doses. Exercise, the only thing that can increase the number of mitochondria, so as you're getting some energy, really get that body moving. Methylfolate, sometimes in doses up to 10 milligrams a day or even higher. I've gone up to 2 milligrams per kilogram body weight a day. Kind of crazy, but it works. And there's a lot of combination products out there. There's other things there, but there'd be a whole lecture on this. So starting labs I find the most helpful. A CBC with DIF is going to give you a lot of information about what kind of infection might be going on or if there's any anemia. A chem panel, homocysteine, vitamin D, a ferritin to look at iron storage, and also an iron panel. So if the iron levels are normal but the ferritin is high, you actually know you just have inflammation, because ferritin can falsely get elevated in an inflammatory state. You want to look at thyroid function. They're talking about this in the other class, but I would do a free T4, a free T3, a total T3, and a reverse T3 to really get the full picture of what's going on. You do your antibodies as well at some point, probably do a TSH at some point, but that's not going to tell you as much. Stool testing, I like some of the comprehensive digestive stool analysis. It tells me so much, and I'm a huge fan of organic acid testing. Provoked metal testing is also helpful. So CBC, you can read this. The biggest thing here is you want to look at the size. So when you're looking at the MCV, if it's large in size, so if the MCV is 98 or more, you're thinking B12 or folate deficiency. And if you've replenished someone in B12 and folate and it's not changing, then you're thinking of B6 deficiency. If the cell size is really small, on the small end, I would say maybe 83 or below, you're thinking low iron and or low copper. The other thing here on the low white blood cells are in our patients, the white blood cell actually tells me a lot. If the white blood cell is below 3.5, but probably below 4, I know that they're a little bit depleted. I need to give things to turn up the immune system. So I'm probably going to be thinking mushroom extracts. I'm going to be thinking, like, I can actually go pretty hardy with this person. If they have high white blood cells, I know their immune system's pretty overactive. They're probably going to be pretty reactive. I wouldn't do mushrooms, and I'm wanting things to kind of dial that down. So I would take things slow. Chemistry panel, just kind of a couple tidbits I'll highlight. The low alkaline phosphatase. So if you have a low alkaline phosphatase under 50, you've got to be thinking zinc deficiency, and I'm always thinking a cryptopyroluria issue. So look for some of those signs, maybe white spots on the nails, possibly just everything else isn't working, just get them on some zinc. The albumin and the protein can be really good indicators of protein and or fat absorption. So if that albumin is below 4 and that protein's running low, but they eat a lot of protein, you either need hydrochloric acid or something with some lipase and protease. And I already talked about the CRT. Okay, organic acid testing. It's going to show you a little bit of everything. So if you're not familiar with organic acid testing, Some of the labs actually put on classes, and I am going to give a little plug on this one for Great Plains Lab because they actually do a very good training on interpreting an organic acid test. It's a weekend course. They're often local. You will come out of there knowing you can run this test on someone and you have a snapshot of a little bit of everything. Specifically, all the different B vitamin markers. You're going to look at their glutathione status. You're looking for overgrowth of some of these bugs that may not actually grow out in a stool sample because it doesn't culture out. So you'll see markers of bacteria, yeast. You can actually see some indirect markers of molds. Definitely looking for different strains of Clostridia. You can see that balance of dopamine, serotonin, quinolinic acid, which is going to be that brain inflammatory marker, overall mitochondrial needs, oxalates, and ammonia. The orotic acid, a lot of times we find with methylation, is if that CBS pathway is not working, we get a backup of sulfur and ammonia, which leads to a lot of that brain fog. And so this person needs more water, but they probably need charcoal and yucca and some of those things to bring that down.